All right, so this is Niall, YL, and Matt. This is our presentation over cerebral palsy. So, what is cerebral palsy? Cerebral palsy is a group of permanent disorders of the development of movement and posture, causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. That definition is right out of our textbook. So these are the motor disorders, or rather, the motor disorders of cerebral palsy are often accompanied by disturbances of sensation, perception, cognition, and communication, as well as behavior and seizures and other musculoskeletal problems. There is no upper age limit that has been determined for postnatal onset, so children are being diagnosed with CP throughout infancy and into early childhood. So the incidence of CP, the National Institute of Neurological and Communicative Disorders and Stroke, or the NINCDS, is the landmark study for CP incidence and is often referenced in studies today. The most recent studies of CP prove that the incidence is 2 to 3 cases per 1,000 live births in the US, UK, Australia, Sweden, and Europe. The survival of infants, um, both with and without CP, have improved over time, but the prevalence of CP has remained the same. This is due to the increase in CP within the population of preterm and very preterm infants that may not have received that diagnosis before. The etiology of CP, there is no single specific cause, um, but the potential causes are known to occur in the prenatal stage of development and are grouped with congenital problems in the perinatal and postnatal time periods. Prenatal events are thought to be responsible for about 75% of all CP cases. Below here, you see 3 charts out of our textbook for prenatal causes, perinatal causes, and postnatal causes. I'm not going to go through those just for the sake of time, but they're there. You guys can read them if you like.
Okay, so now when addressing the diagnosis and prognosis of children with cerebral palsy, typically when they're 2 years or younger, what can be seen is when they present with abnormal muscle tone, atypical posture, or they just still have the persistence of the primitive reflexes. If there's milder cases of CP and the symptoms are not as prevalent, they can be diagnosed until 4 to 5 years of age. They evaluate the motor skills, imaging, as well as evidence that symptoms are not progressing when looking at different elements when trying to diagnose kids with cerebral palsy. Usually, MRIs are preferred when dealing with looking at imaging, but cranial ultrasounds are used for high-risk preterm infants because it's less invasive. But again, MRI is the imaging preferred because it provides a greater detail of brain tissue and structure. With typical children who have CP, they show abnormalities 70 to 90% of the time when the results show MRI. Physicians, though, should be cautious because, as we know, what shows up on the imaging may not correlate directly with physical presentations. So that should be taken into account when looking at their functional abilities. The book does mention that cerebral hemorrhages can be associated, and they're graded 1 to 4 depending on the severity. The extent and location of white matter damage can lead to different subtypes of cerebral palsy. So in the book, they mentioned that, for an example, localized damage to the cortical spinal tract can lead to spastic diplegia. And for example, if it extends a little laterally, quadriplegia can often be the result. So just different lesions and the extent to which white matter's damage can lead to different subtypes. The quality of the infant's general movements have been used by doctors and researchers to evaluate brain function. There was a study done where they took 84 preterm infants and they found abnormalities in their general movements. So typically you would have fidgety movements within a baby, you know, with their limbs, neck, and trunk. And they found that there was a predominance of cramped synchronous general movements instead of those fidgety movements. The sensitivity was 100% and the specificity ranged from 92.5 to 100%. So both were very high. General movements can be predictive of later CP and are the best expression of functional motor development. So when classifying cerebral palsy, they typically look at three different categories. First one is the type of movement disorder. Second is the anatomical location of the child's impaired motor function. And the third one is the scope of motor dysfunction. First one, with the type of motor disorder, there are four different subtypes. You have spastic, hypotonic, dyskinetic, or ataxic. The next category is anatomical location of the limbs affected. So you have hemiplegia, diplegia, and quadriplegia. Hemiplegia, one arm and one leg on the same side is affected. Diplegia, both lower extremities, and quadriplegia, all four limbs, as well as back and neck musculature are involved. The third one, which is the being classified by their motor dysfunction, is typically based off of the first two. Once they're classified within the first two, that's when further differentiation is made based on their severity. So this is regarding the third one. This is a standardized system that's straight out of the book, table 5.9, called the gross motor function classification system. It's used to measure the severity of movement disability in children with CP. So it ranges from level 1 to level 5, progressing to more dependent, where level 1 starts with they're walking without restrictions. Level 2, they're walking without assisted device, but they still now have some limitations walking outdoors. Level 3, they're walking with assisted device and they have limitations walking outdoors. Level 4, they're more self-mobile and they're more dependent. They're being transported or using a power mobility. And level 5, even with the assisted devices, they're still severely limited.
Okay, so like already mentioned by YL, there's different types of movement disorders. There's spasticity, dyskinesia, ataxia, or hypotonia. So the first one I'll go into is spasticity. It's hypertonia in which resistance to passive movement increases with an increasing velocity of movement. So it's velocity dependent. This occurs in approximately 75% of all children with CP. It is the most common neurologic abnormality seen in children with CP. The muscle changes with spasticity can cause secondary disorders such as hip dislocations, scoliosis, knee contractures, or torsional malalignment of the femur and tibia, amongst many other things. These changes often have significant effect on function, including effortful gait patterns, difficulty assuming sustaining seated positioning, and difficulty performing self-care activities. So over here on the right, we have the modified Ashworth scale, which we're all familiar with. That's what they would use to kind of grade this. So the next type is dyskinesia or dyskinetic. Dyskinesia and movement disorders result in uncontrolled and involuntary movements. There's several subcategories of dyskinesia, including athetosis, rigidity, tremor, dystonia, valismus, or chorioathetosis. Some common abnormalities during imaging include deep gray matter lesions and occasionally periventricular white matter lesions, as well as basal ganglia lesions. So athetosis seemed to be the big one in the book. Athetosis always has involuntary movements that are slow and writhing. So there would be abnormal timing, abnormal direction, abnormal spatial characteristics, and will usually involve large motions of the more proximal joints. So it's rare as a primary movement disorder and is most often found in conjunction with chorea and secondary to spasticity. So it's not uncommon for kids with CP to have more than one type of movement disorder. So athetosis is caused by an impairment of the cortical basal ganglia thalamic loop, which functions as a sensory and motor feed-forward and feedback circuit. Older individuals with athetoid CP are at risk for developing neurologic deficits secondary to intervertebral disc degeneration and cervical instability. So a study done showed that 51% of individuals with athetoid CP displayed advanced disc degeneration, which is much higher than average for this age group. Individuals with athetoid CP typically attempt to initiate and control movements with the jaw and head, which is what results in the possible cervical issues such as instability, stenosis, spinal cord injury, or TMJ dysfunction. When athetosis is the primary movement disorder, even though that's pretty rare, cognitive abilities tend to be underestimated due to the associated dysarthria, but intelligence tends to be at normal to above levels. People think they have cognitive issues just because they can't speak due to the initiating movements with the jaw, but intelligence tends to be okay. So the other type of dyskinetic movement disorders, you have rigidity, which is not very common. That's resistance to both passive and active movements. That's not velocity dependent. Tremors are rhythmic movements of small magnitude, usually involving smaller joints and rarely occurring as an isolated disorder. These are usually in conjunction with athetosis or ataxia. Dystonia is slow motion with a torsional element that may involve one limb or the entire body, and the pattern may change over time. Bulismus is the most rare movement disorder, involving random motions and large, fast patterns, usually involving a single limb. And then chorioathetosis involves jerky movements and usually impacts the digits and varies in its range of motion. So next is ataxia, which is primarily a disorder of balance and control and the timing of coordinated movements. This is associated with weakness in coordination and a wide base gait. There's also a noted tremor. A result of deficits in the cerebellum, but a lesion is not always present with neuroimaging. This goes back to what Wael said, is that we can't always take what we see on the imaging as gospel because the physical presentation in the imaging don't always line up. So only 39% of children with ataxia present with a specific cerebellar lesion. This often occurs in combination with spasticity and athetosis, and children with ataxia have difficulty with transference of skills that would benefit from a task-oriented approach to therapy. So the example that was in the book revolved around bus steps, and what it said is if a kid has a particular problem with walking down the steps of a bus to get on or off, you should try to mimic that as closely as you can in your therapy and mirror those situations to really work on those specific scenarios. So the last one is hypotonia. Hypotonia can be permanent, but is more often transient in the evolution of athetosis or spasticity and might not represent a specific type of CP. So infants who present with hypotonia throughout the trunk and extremities will often develop spasticity beginning distally and progressing proximally. A common mixed tone pattern is seen in some children with quadriplegia, with spasticity evident in the lower extremities and hypotonia in the trunk and the neck.
Okay, so now we have a table that focuses on the anatomical locations involved. So we have the three: diplegia, hemiplegia, and quadriplegia. So we'll just dive into some of the main ideas for each one. Diplegia, first off, primarily affects bilateral lower extremities. They typically have some lesions that can be caused by hypoxia in the periventricular white matter that can lead to some spastic diplegic cerebral palsy. Diplegic is the most common form of spastic CP, and it does involve some gait defects such as equinus and crouch gait when we're talking about both of the lower extremities being affected. With this subtype of CP, energy expenditure is much greater because you are dealing with both lower extremities that have a spastic and weakness component. They often require assistive devices such as lofting crutches or a posterior walker when moving around. And when you think of long distance mobility, you would have to incorporate a scooter or wheelchair that may be necessary. For hemiplegia is when typically the upper extremity and the lower extremity on the same side of the body is affected. The book dives into 4 main brain lesions that could result um, due to either a cervical subcortical lesion, brain malformations, non-progressive postnatal injuries, or again, periventricular white matter abnormalities. This subtype usually presents with more contractures and limb length discrepancies in the involved side. And the book states because the affected side deals with more muscle spasticity that causes a decrease in muscle as well as bone growth. And in the long run, that causes decreased range of motion. Children with this type of subtype tend to achieve all the gross and fine motor milestones, but not within the typical time frame. So they'll be a little further back than what the typical time would be. The book mentioned 2 certain tools used to assess children with hemiplegia. The first one is Shriner's Hospital Upper Extremity Evaluation, which assesses the client's actual function of the affected extremity. And the second one is Assessing Hand Assessment, which is AHA, which looks at how effectively the affected hand and arm is used in bimanual performance. I attached a link below for both of them that kind of go over the detail of them. The last one is quadriplegia, which is when voluntarily muscle control of all 4 extremities is severely impaired, and typically neck and trunk musculature are involved. Again, this also deals with periventricular white abnormalities being observed in imaging, but this one also can include lesions that affect basal ganglia or occipital area that can lead to visual impairments and seizures, which is very common with this subtype. They can range from being either normal to severely impaired when dealing with cognition, as well as there's a wide range with gross and fine motor abilities. They can be ambulatory for household distance with an assistive device to being dependent for all care. Common equipment recommendations is mechanical lift systems, wheelchair, standers, gait trainers, and bath, toileting, or feeding systems. Okay, so as we mentioned before, the gross motor functional classification system is also helpful to estimate future ambulatory potential in children with ZP. And so to know what is abnormal in someone, it's good to know what's normal in gait. So these are the prerequisites that someone should have in their normal gait. So they should have a stable lower limb in the stance phase, the clearance of the ground by the foot in swing phase, proper positioning of the foot in dorsiflexion with terminal swing, adequate step length, and maximal energy conservation. So damage to the CNS causes loss of selective motor control, abnormal muscle tone, an imbalance between your agonist and antagonist muscles, and also poor equilibrium, which as a consequence, many or all of those prerequisites of gait are gone with children with CP. And then, so some of the deviations in gait that we see have 4 main causes, being weakness, abnormal bony alignment, muscle contractures, and muscle spasticity. These are 5 different gait patterns that we're going to dive into that you will see with children with cerebral palsy. So first one being hemiplegic gait. So these children usually walk with their more planovalgus gait pattern. And the most common gait abnormalities we find in these children are equinus being most predominant, stiff knees, in-toeing, excessive hip flexion, and crouch, not as much as equinus, because the primary neuromuscular impairment here is gastrospasticity. And so the most obvious feature typically noted is asymmetrical weight shifting to the involved side with walking. So there are 4 types of hemiplegic gait, going from least involved to most involved. So in type 1, you would have drop foot in your swing phase, but you would still have normal dorsiflexion, passive range of motion. So you won't have any calf contractures, and your ankle dorsiflexion is still relatively normal. Then as you go further into the types, it gets more involved. We'll just go to type 4 being the most involved. So they have hyperactivity of the iliopsoas and the hip adductors. This limitations prevent full hip extension at terminal swing phase. And so they walk with sort of a circumducted gait, which would account for the hyperactivity of the iliopsoas. For the diplegic gait, for this gait, bone deformities of the long bones are very common. And with that, muscle effectiveness is reduced when bony malalignment occurs. And this dysfunction is often referred to as lever arm disease. And the common gait deviations you see here are stiff knees due to overactivity of the rectus femoris muscle, crouching with overactivity of the hamstrings, and weakness of the quad. Excessive hip flexion. So the child presents with an anterior pelvic tilt, hip flexion, knee flexion, and ankle equinus. And so it appears to look like a child is jumping because he has a strong quadricep contraction during the late stance phase. And so they also have in-toeing and equinus. And the most common foot deformity seen with this gait is the foot dropping into a more plano-valgus position. The next gait being quadriplegic gait. So most children with quadriplegic CP are not community ambulators. They do have some ability to ambulate with an assisted device at home or in a therapeutic setting. The most common deviations seen here are stiff knee, 93%, crouching, excessive hip flexion, in-toeing, equinus, and excessive hip adduction or scissoring. And so you would see, as you see in the picture at the bottom of the slide, they have equinovalgus feet. And so this impairment can really hinder them with walking also. And even though functional community is not a realistic goal, as PTs, we want to encourage ambulation. And the only way some patients can get around is that power mobility. And this is a discussion we want to have with the family so they have time to accept it in terms of their best shot for long-term mobility. Moving into athertotic and ataxic gait. So athertotic is a gait that is very difficult to describe and even more difficult to address. That is straight from the book. Athertotic movements are usually first noticed at 2 to 3 years of age, and by years 3 to 5, the patterns are already consistent and they don't change much. So their tone fluctuates. They can have an underlying low postural tone, and then that can fluctuate to a high level of stiffness. And so gait pattern in these patients are poorly graded and in total patterns of movement. Orthopedic and physical therapy treatments usually have little effect on athertotic movements. However, they have shown that weighted vests and ankle weights are sometimes helpful in improving balance with this group. Moving on to ataxic gait, with these patients, they are going to be uncoordinated. They're going to have general unsteadiness, a widened base of support because they feel so unsteady. And so as a result of that, they'll walk slower and have a prolonged stance phase. And so they found with ataxic gait, it did help if you have repeated motor training, taping, light weighting of the limbs did have some benefit. So it's probably a common theme between these two gait. So moving on to fine motor, adaptive, and self-care skills. So there was a study conducted that determined that fine motor function, including dexterity and visual motor control, were the most important motor factors associated with health-related quality of life. And so as a PT, when you're observing these children, watching them do simple things as putting on or taking off their socks, shoes, and coats, you kind of want to assess their sitting balance, mobility, and control of their head and trunk, weight shifting through the pelvis, and the use of mobility of the arms. And through watching these motions, you should ascertain the following of how did the particular skills get accomplished, what degree of assistance do they need, at what point was assistance necessary, and whether the child accomplished the task using compensatory methods, which would lead to structural changes and potential deformities down the line. With speech and language considerations, SPTs, we can offer important information to the speech and language pathologists regarding the speech and language and the quality of respiration seen throughout treatment. And we should ask the parents and caregivers and teachers if there are any noticeable changes with the child's speech or functional areas, such as chewing, sucking, swallowing, feeding, or drinking. And we can incorporate some speech and language pathologists and PTs during our PT session, which would be beneficial to the patient. So mobility of the vertebral column and rib cage can positively impact respiration and speech and voice control for these patients. And co-treatment with a speech or language pathologist can be beneficial to the child, often resulting in a more rapid progress. And so with establishing functional outcomes, we want them to be functional, and they should be identified as short and long-term outcomes. So an example of being functional is an infant will reach for and grasp a toy suspended in front of him or her. And so we want these goals to be aimed at changing the child's impairment goals are aimed at changing the child's impairment and are not functional in nature. So that differentiates them from the outcomes. And so this would be lengthening of the hamstrings, deeper respirations. And so therapists will have many treatment goals in a single treatment session. And these are all aimed towards achieving the session's functional outcome. In this picture here, it gives you examples straight from the book of functional outcomes that you can have for a patient. All right, so when talking about therapeutic interventions, whether that be strengthening or stretching, the National Strength and Conditioning Association established strength training guidelines for children and adolescents in general. So not just for cerebral palsy, but just children in general. And through evidence, there is inadequate evidence for exercise prescription for kids with CP, but they have said that this is a good framework to use as a starting point. So it's a table 5.3 in your book where they describe the warm-up, which is 5 to 10 minutes of dynamic activities, and then they take you through different types, intensities, intervals, frequencies, and so on. If the child is too weak or has poor postural control, we can take them through a gravity eliminated position to make it a little easier, or assist them to complete the motion against gravity. There has been a new area of discussion which involves virtual reality programs to help strengthening. So they have mentioned a home-based virtual cycling program for children with spastic CP. It's still new, so there's not a lot of evidence on it, but it just shows that they are progressing in that area. And of course, you want to consistently implement regular stretching to maintain full range of motion and prevent as best as we can or minimize contractures. Neurodevelopment training. So initially the definition of it was this isn't a set of techniques, but more of an understanding of just the process of motor control and the components of what makes up a functional motor task. There has been a new sort of theory called the neuronal group selection theory, where it's used to explain how the nervous system changes as a result of experience. So it emphasizes that the concept is a result, development is a result of complex relationship between genes and the environment. They say that brain development is fostered by the participation in functional activities within an appropriate environment. The ultimate goal is for the child to have the most independent function possible according to their age and abilities. And our treatment sessions should be directed towards a functional outcome and include as much client-initiated movement as possible, as well as have an effective carryover from the treatment to daily life. Sensory integration and sensory processing disorder. So sensory integration, this is when we provide the child with a guided sensory input designed to produce a response that's more effective than their previously observed behaviors. We try to incorporate strategies that help achieve them sustain an optimal level of arousal in all environments. Conversely, this also works for children who has high arousal to begin with, and we can assist in allowing them to calm and allow them to engage in activities in the classroom or any other purposeful interactions within the environment. Sensory processing disorders. So children to begin with, when they have cerebral palsy, they tend to have trouble processing sensory input and have an even greater difficulty producing a desired motor output. So this is where the therapist tries to provide the child with a sensory information that will help them interpret any sensory information coming in and then provide a motor output that is functional. And then as they move on and it's applied throughout the child's day, they'll be able to quickly adapt the information in a functional way. Some examples include floor play, rolling over, pushing up, moving extremities, as well as purposeful play activities requiring the use and strength of hands, such as Play-Doh or playing in wet sand. Other treatments, modified constraint-induced movement therapy. We've touched on this lightly. The modified version of it is that they constrain the unaffected arm with a mitten or a glove to be better tolerated by the child, and they then ensue with intensive treatment techniques used to train the involved upper extremity. It usually involves the affected upper extremity in 90% of the patient's day over a 2-week period with organized interventions for 6 hours a day. And that's out of the textbook. So that's typically what the guidelines look like with this sort of treatment. Treadmill training, they walk on the treadmill to improve their ability to walk at home and in the community. Electrical stimulation can be used for different purposes, either pain control, edema, muscle strengthening, but there are considerations that we have to take into play here where there's child's age, skin sensitivity, cognitive ability, and tolerance to stimulation that has to be considered when deciding whether to use this or not as a treatment. The book mentioned 3 different types: NEMS, functional electrical stimulation, and threshold electrical stimulation. We know what the first 2 are. The threshold electrical stimulation, the book described it as low-level subcontraction electrical stimulation that they apply during sleep. So the idea is to increase blood flow during a time where they have heightened trophic hormones, which the idea of is it would result in increased muscle bulk. So it's pretty interesting. There's more evidence with NEMS and FES rather than TES. Aquatics, we know how beneficial aquatics can be when being involved as a treatment option. Hippotherapy is when they use a horse for rehabilitation, where they focus on recreation or riding skills for disabled riders. So the movements of a horse are deemed therapeutic, and they label the horse as a therapeutic tool, and it's used to promote relaxation, increased range of motion, strengthening, and proximal control. The therapist obviously needs to have special training and clinical experience. Lastly, community programs, having the children participate with friends and join in on the fun to raise self-esteem. With home and school management, home programs should be designed to kind of reinforce what they're learning in physical therapy sessions, whether that be movements, positions, skills. There was a study done that recommended that the activities be embedded in their daily routine to promote more practice opportunities, whether that be activities such as diapering, dressing, feeding, bathing, and so on. For school, the therapist should evaluate any barriers to independence in the classroom and alignment at different times in the day while a child is sitting in their personal wheelchair or classroom seat. The opportunities available to stand and, when applicable, ambulate safely should all be taken. Consistent movement throughout the day, such as standing, walking between activity centers in the classroom, or participating in PE, will provide relief from the sitting position.
Okay, so now we're going to cover adaptive equipment and assistive devices very briefly. So some common things that you're going to see kids with CP using are standers. There's several different types of standers, being supine, prone, upright, or sit to stand standers. Um, just for the sake of time, we're not going to go real in depth on that sort of adaptive equipment. The same with assistive devices, depending on their level of function and ambulation, you're going to see different things such as gait trainers, walkers, crutches, and canes, all being used by kids with CP. So the next thing is lower extremity orthotics. Again, not going to go too in depth. We'll probably cover most of these in O&P at some point, but these are some common things that you could see a child with CP wearing. So some non-PT treatment options. Um, you have neuromedical interventions. So you have oral medications and neuromuscular blocks. Those, as well as neurosurgical interventions, mostly revolve around the reduction of spasticity, um, trying to limit some of the involuntary movements that these kids are struggling with. There's also orthopedic interventions to address scoliosis, femoral anteversion, hip subluxation or dislocation, hip adductor contracture, hip flexor contracture, knee flexion contracture, and the list goes on. You guys can read from there. So this has been our presentation. Thank you for listening. Hopefully you enjoyed it. Hopefully you learned a couple things. Thanks.